The kidneys have no warning system for the first 80% of their decline. That is not a rhetorical device, it is the clinical reality of how chronic kidney disease progresses, and it is the reason kidney failure remains one of the most preventable and most preventably missed conditions in modern medicine. The kidneys are paired organs with extraordinary redundancy built into their architecture. Each kidney contains approximately 1 million nephrons, the individual filtration units that clean the blood, regulate fluid balance, manage electrolytes, and control blood pressure. When nephrons are damaged and lost, the remaining ones compensate. They enlarge, they increase their individual filtration rate, they maintain overall organ function despite progressive structural loss. And because this compensation is so physiologically effective, there are no symptoms, not at 20% loss, not at 40%, not at 60%. The standard annual blood tests may show entirely normal creatinine values during this entire period because the compensating nephrons are maintaining output above the threshold at which standard markers rise. By the time the kidneys send the 6 symptoms in this video, the compensation is failing. The remaining nephron population is no longer sufficient to maintain the filtration, regulatory and hormonal functions the organ is responsible for. Waste products that should be cleared are accumulating in the bloodstream. The pressure regulation the kidneys govern is failing. The hormonal signals the kidneys produce, governing red blood cell production, bone mineral metabolism, and cardiovascular tone, are deteriorating. The 6 symptoms are not early warnings from a kidney in distress. They are late warnings from a kidney whose reserve has been substantially consumed. And that distinction between early and late, between the long silent period and the symptomatic window, is the clinical reality this video is designed to communicate as clearly as possible. The phrase final warning is not alarmist, it is anatomically accurate. These 6 symptoms represent the stage at which the kidney's compensatory capacity is running out, and intervention becomes urgent rather than simply advisable. At earlier stages, the long silent stages, intervention is straightforward, highly effective, and can halt the progression of disease entirely. At the stage defined by these 6 symptoms, intervention is still possible and still meaningful, but the window for full preservation of remaining function is narrowing. Understanding these symptoms and understanding what they mean in terms of the biology they are reflecting is the information that changes what happens next. Hi, I'm Dr. Alex. I'm an emergency medicine doctor, and after nearly a decade in the AAN-EE, end-stage renal failure is one of the presentations I encounter with a regularity that should not be necessary. It is a condition that, in most cases, announced itself years earlier in a GP's blood results, a mildly elevated creatinine, a slightly reduced EGFR that was noted and not acted upon, a urinalysis showing protein that was attributed to a transient cause. The disease progressed quietly through those years, while the opportunity to slow it decisively was present and unused. By the time the patient reaches an emergency department in fluid overload, with uremic symptoms and a potassium level that threatens cardiac rhythm, the conversation is about dialysis rather than prevention. That conversation should not be happening as often as it does. These videos exist to shift it earlier. If you are watching this, something in that description has resonated. I want to make you a direct promise. I will keep producing the most clinically rigorous, practically useful content I can, grounded in current research, to give you the understanding your medical appointments may not always have provided. All I ask in return is that you give this channel a chance and hit the subscribe button. If you reach the end of this video and feel you have not learned something genuinely valuable, you are entirely free to unsubscribe, no hard feelings whatsoever. But if you give me your time, I will give you everything a decade on the front line of emergency medicine has taught me. Please subscribe to help this content reach the people who need it. And let's go through the 6 symptoms. To understand why these 6 symptoms appear at this specific stage of kidney disease and not earlier, you need to understand what the kidneys actually do and why the compensation mechanism that protects against symptoms for so long ultimately fails in a way that produces this particular cluster. The kidneys perform 6 distinct physiological functions, each of which degrades in a specific way as nephron mass is lost, and each of which contributes to one or more of the 6 symptoms. The first is blood filtration and waste clearance. The kidneys filter approximately 180 litres of blood per day through the glomeruli, the microscopic capillary networks at the centre of each nephron. This filtration removes urea, creatinine, uric acid, excess electrolytes, and a range of metabolic byproducts from the bloodstream. When sufficient nephrons are lost, this clearance capacity falls below the rate at which waste is produced, and these substances begin to accumulate. The syndrome produced by the accumulation of nitrogenous waste, uremia, affects the brain, the skin, the gastrointestinal system, and the cardiovascular system simultaneously. The symptoms of uremia are among the 6. The second function is fluid and electrolyte regulation. The kidneys govern the body's total fluid volume by adjusting the amount of water retained or excreted in response to hormonal signals, primarily antidiuretic hormone and aldosterone. They regulate sodium, potassium, phosphate, and bicarbonate balance with extraordinary precision. When filtration capacity falls below a critical threshold, these regulatory functions become impaired. Fluid accumulates in the tissues, particularly in the legs and feet, and in the pulmonary circulation. Electrolyte imbalances develop, with potassium and phosphate rising to levels that carry direct cardiovascular and neuromuscular risk. The third function is blood pressure regulation. The kidneys regulate blood pressure through 2 primary mechanisms. The first is volume control. By adjusting fluid retention, the kidneys directly control the volume of blood in the circulation, which is one of the 3 determinants of blood pressure. The second is the renin-angiotensin-aldosterone system, a hormonal cascade the kidneys initiate in response to perceived low blood pressure or low sodium, which produces vasoconstriction and sodium retention. When kidney function is impaired, both mechanisms become dysregulated. The kidneys overactivate the renin-angiotensin system, driving blood pressure up, which simultaneously damages the glomeruli further, creating a vicious cycle in which hypertension both causes and is caused by progressive renal impairment. The fourth function is erythropoietin production. The kidneys produce erythropoietin, the hormone that signals the bone marrow to produce red blood cells. As nephron mass is lost, erythropoietin production falls. The bone marrow receives a diminished signal. Red blood cell production declines. The resulting anemia, the anemia of chronic kidney disease, contributes to the fatigue, breathlessness, and cognitive effects that appear among the 6 symptoms. The fifth function is vitamin D activation. The kidneys perform the final hydroxylation step that converts vitamin D into its active hormonal form, calcitriol. Calcitriol governs calcium absorption from the gut, regulates parathyroid hormone secretion, and maintains bone mineral density. When kidney function declines, calcitriol production falls, calcium absorption decreases, and parathyroid hormone rises in compensation, driving calcium out of bone and into the circulation, weakening the skeletal structure and producing the characteristic bone disease of advanced chronic kidney disease. The sixth function is acid-base regulation. The kidneys excrete the daily acid load generated by normal metabolism and reabsorbed by carbonate to maintain blood pH within a narrow, physiologically essential range. When filtration capacity is insufficient, metabolic acidosis develops, a state in which the blood's pH falls below its optimal range, producing fatigue, muscle wasting, bone loss, and acceleration of the kidney disease itself. 6 functions, 6 failure modes, all converging on the symptomatic picture that appears when compensatory capacity is finally exhausted. The 6 symptoms below are the clinical expression of that convergence, each one mechanistically connected to one or more of these failing systems, each one appearing at the stage when the compensation that has protected against symptoms for years is no longer sufficient. Peripheral oedema, the accumulation of fluid in the soft tissues of the lower extremities, is one of the earliest of the 6 symptoms to become visibly apparent and one of the most consistently misattributed. In most people who experience it, the explanation offered is gravitational, prolonged sitting or standing, long-haul travel, age-related venous insufficiency. These are legitimate causes of lower extremity oedema in many presentations. When the oedema is produced by failing renal fluid regulation, its character is specific. It is typically bilateral, pitting, meaning the indentation produced by pressing the tissue persists for several seconds. and present regardless of the day's activity pattern. It does not resolve with leg elevation in the way that gravitational oedema does. The mechanism is twofold. First, as kidney function declines and sodium excretion becomes impaired, sodium accumulates in the body and water follows osmotically, expanding the extracellular fluid volume. This volume expansion seeks the path of least resistance, the interstitial spaces of the lower extremities, where hydrostatic pressure from gravity assists fluid accumulation. Second, patients with the protein loss of nephrotic range proteinuria, a feature of several of the conditions that drive chronic kidney disease. The fall in serum albumin reduces the oncotic pressure that normally keeps fluid within the vasculature, accelerating the movement of fluid into the interstitium. Research published in the Journal of the American Society of Nephrology has documented bilateral pitting edema as a presenting sign in patients with eGFR values below 30 milliliters per minute per 1.73 square meters, the threshold that defines stage 4 chronic kidney disease, representing a loss of at least 70% of normal renal filtration capacity. The edema is not a minor comfort issue, it is a systemic fluid regulation failure. The fatigue of advanced chronic kidney disease has a clinical character that distinguishes it from the fatigue of sleep deprivation, and anemia alone or overwork. It is a multi-mechanistic, pervasive exhaustion that encompasses physical, cognitive, and motivational domains simultaneously. Patients describe it consistently as a heaviness that cannot be wrested away, a depletion that is present at the start of the day and worsens with minimal exertion, and a cognitive dimension, a difficulty initiating and sustaining mental effort that feels distinct from simple tiredness. 4 mechanisms converge to produce this quality of fatigue at this stage of kidney disease. The first is the anemia of chronic kidney disease as erythropoietin production falls, red blood cell production declines, oxygen delivery to every tissue is reduced, and the cellular energy deficit that results produces the physical component of the fatigue. The second is the direct neurosuppressive effect of accumulating uremic toxins, urea, indoxyl sulfate, p-cresyl sulfate, and a range of other nitrogenous byproducts that cross the blood-brain barrier and impair neuronal function. The third is the metabolic acidosis that developing renal failure produces, which suppresses cellular energy metabolism and drives protein catabolism, contributing to the muscle weakness that accompanies the fatigue. The fourth is the systemic inflammatory state that advanced chronic kidney disease generates, with elevated pro-inflammatory cytokines producing a fatigue phenotype virtually identical to that of other chronic inflammatory conditions. Research published in the American Journal of Kidney Diseases has documented the multi-mechanistic nature of renal fatigue and its poor response to single-mechanism interventions, noting that the fatigue of advanced chronic kidney disease often represents the most functionally limiting symptom of the condition from the patient's perspective. The urine is the most direct observable output of kidney function, and changes to its characteristics represent some of the most specific and diagnostically informative signals the kidney produces. At the stage defined by these 6 symptoms, the urinary changes that appear carry a precision of clinical meaning that most people who experience them never recognize. Foamy or frothy urine is among the most specific and most overlooked of these signals. The foam is produced by protein in the urine, proteinuria, which acts as a surfactant, creating bubbles that persist when urine hits the toilet water in a way that normal urine, which contains no significant protein, does not. The presence of significant proteinuria indicates that the glomerular filtration barrier, the specialized structure that normally prevents proteins from passing from the blood into the filtrate, has been damaged. This damage is both a marker of existing renal injury and an independent driver of progressive nephron loss. Research published in the New England Journal of Medicine has established proteinuria as one of the strongest independent predictors of chronic kidney disease progression, with the magnitude of protein loss correlating directly with the rate of subsequent GFR decline. Changes in urination frequency and volume are equally informative. As filtration capacity falls, the kidney loses its ability to concentrate urine effectively, producing a paradoxical increase in urine frequency and volume, particularly at night, as the kidney attempts to maintain clearance through volume rather than concentration. Later in the disease course, as filtration falls further, urine output may actually decrease, a sign of more advanced functional loss. Changes in urine colour to darker amber, tea-coloured, or frankly bloody indicate either hematuria from glomerular damage or the concentration effects of reduced filtration and increased pigment excretion. Any of these changes persisting over days rather than representing a single isolated episode demands urinalysis and renal function assessment without delay. Uremic pruritus, the widespread persistent itching that accompanies advanced kidney disease, is one of the most clinically distinctive and most frequently ignored symptoms of the condition. It presents without a visible skin rash or lesion. It does not respond to antihistamines because its mechanism is not histamine mediated. It is characteristically worse at night, disproportionately affecting the back, the extensor surfaces of the arms and legs, and sometimes the face. In its more severe presentations, it is sufficiently distressing to significantly impair sleep and quality of life. And in most of the people who experience it, it is attributed to dry skin, to aging, or to an allergic cause that repeated investigation never identifies. The mechanism involves the accumulation of uremic toxins in the skin, particularly phosphate, which deposits in the dermal tissues as a consequence of impaired renal phosphate excretion and the secondary hyperparathyroidism that develops as the kidney loses its vitamin D activating function. The phosphate deposition activates peripheral itch receptors and stimulates a neurogenic itch response to the MUM opioid receptor pathway. Simultaneously, the systemic inflammatory state of advanced chronic kidney disease produces elevated levels of interleukin-31, a cytokine with a specific role in itch signaling, and the uremic toxins that accumulate in the skin directly modulate the activity of sensory nerve fibers. Research published in the Journal of the American Society of Nephrology has documented uremic pruritus as present in up to 40% of patients with stage 4 and 5 chronic kidney disease, and as the symptom most strongly associated with reduced quality of life and sleep disturbance in this population. The itch is not a skin problem, it is a renal problem expressed through the skin. Breathlessness in the context of advancing kidney disease is a symptom that arrives from two distinct directions simultaneously, which is part of what makes it feel so alarming to the people who experience it and so clinically urgent to those who assess it. The first mechanism is fluid accumulation in the pulmonary circulation. As renal fluid regulation fails and sodium and water retention increases the total extracellular fluid volume, the excess fluid does not accumulate only in the dependent tissues of the lower extremities. It also accumulates in the lung interstitium and, in more advanced cases, in the alveolar spaces themselves, pulmonary edema. The consequence is a progressive reduction in the lung's diffusion capacity, producing breathlessness on exertion that worsens as activity level increases and as fluid accumulation progresses. Characteristic orthopnea, breathlessness that is worse when lying flat and relieved by sitting upright, occurs because the recumbent position redistributes fluid from the lower extremity into the central circulation, increasing pulmonary venous pressure and worsening pulmonary edema. This is a medical emergency when it reaches the stage of acute pulmonary edema, but it presents first as a gradual progressive exertional dyspnea that most people attribute to deconditioning for weeks or months before the severity becomes unmistakable. The second mechanism is the anemia of chronic kidney disease. As erythropoietin production declines and red blood cell production falls, the oxygen carrying capacity of the blood is reduced. The cardiovascular system compensates by increasing cardiac output. The heart beats faster and pumps more volume per minute to deliver sufficient oxygen to tissues running below their normal oxygen supply. Under physical demand, this compensation is consumed rapidly, producing the breathlessness and elevated heart rate of anemia-driven exertional intolerance. Both mechanisms are present simultaneously in advanced chronic kidney disease, and together they produce a respiratory picture that is substantially more severe than either would produce alone. Research published in the American Journal of Kidney Diseases has documented the prevalence of significant exertional dysmuda in patients with eGFR below 30 noting its association with both pulmonary fluid accumulation and the severity of renal anemia. This sixth symptom is the most directly uremic of the six. It is the symptom that most precisely reflects the accumulation of nitrogenous waste products in the bloodstream that defines the clinical syndrome of uremia. And it is the one that most clearly signals that the kidney's detoxification function has been sufficiently compromised to produce systemic toxicity. The metallic taste dysgeusia is produced by the accumulation of urea and other nitrogenous compounds in the saliva. As blood urea nitrogen rises, urea diffuses into saliva, where it is hydrolyzed by oral bacteria to ammonia, producing the characteristic metallic or ammoniacal taste that patients describe as persistent, unrelated to food consumption and impossible to resolve with oral hygiene. The nausea and anorexia that accompany it are driven by both the direct gastrointestinal effects of uremic toxins, which suppress gastric motility and alter the mucosal lining of the stomach and small intestine, and by the central effects of nitrogenous waste products on the hypothalamic appetite regulation centers and the chemoreceptor trigger zone in the brainstem, the same zone activated by other chemical toxins that produce nausea. These gastrointestinal uremic symptoms were historically among the first clinical markers used to identify the need for dialysis initiation before blood tests were routinely available. They represent a degree of uremic accumulation that is directly harmful to the gastrointestinal mucosa and the central nervous system, and that, if not addressed, progresses to more severe manifestations, including uremic encephalopathy. Research published in the Clinical Journal of the American Society of Nephrology has documented the metallic taste and anorexia of uremia as strongly predictive of eGFR below 20 milliliters per minute per 1.73 square meters, correlating their severity with the blood urea nitrogen level and the degree of residual filtration capacity. The taste in the mouth is not a digestive incidental. It is the bloodstream communicating its toxin load through the saliva. Let me address directly what the phrase final warning means in biological terms, because it requires precision rather than emphasis to be clinically useful. The kidneys do not produce symptoms during the vast majority of their decline because compensatory nephron hypertrophy maintains filtration output above the symptomatic threshold. Each remaining nephron works harder. The glomerular filtration rate per nephron rises. The overall GFR stays within a range that standard creatinine-based blood tests mark as acceptable. This compensation is physiologically extraordinary, and it is physiologically costly. The increased filtration pressure within individual compensating nephrons accelerates their own structural damage. The hyperfiltration that maintains function in the short term is itself a driver of progressive nephron loss in the long term. The kidney is in effect consuming its remaining reserve to compensate for the loss of its damaged reserve in a process that is self-limiting in a very specific way. The 6 symptoms in this video appear at the stage where that compensation is reaching its limit. An eGFR of between 15 and 30 milliliters per minute, the range at which these symptoms typically become manifest represents a retention of only 15 to 30% of normal filtration capacity. At this level, waste clearance is substantially impaired. Fluid regulation is failing, erythropoietin production is significantly reduced, vitamin D activation is compromised. The counter-regulatory mechanisms the kidneys use to protect cardiovascular function are failing. The symptoms are not warnings that something might go wrong. They are evidence that something has been wrong for a long time, that the compensation that concealed it has been consumed, and that the remaining functional tissue is now being asked to do the work of a full organ with a fraction of its architecture. The reason these symptoms still constitute a warning rather than simply a terminal description is that even at this stage, intervention meaningfully changes the trajectory. Research published in the New England Journal of Medicine in the Credence and DAPA-CKD trials has demonstrated that pharmacological intervention, specifically SGLT2 inhibitors in patients with advanced chronic kidney disease and proteinuria, produces a 30 to 40% reduction in the composite risk of kidney failure, cardiovascular death, and hospitalization. The pharmaceutical landscape for kidney disease has changed substantially in the past decade, and the degree of protection available to patients who present at this stage and are appropriately managed is substantially greater than it was even 5 years ago. What has not changed is the pattern of late presentation. The standard of care for chronic kidney disease, annual creatinine and eGFR measurement in primary care, is a blunt instrument applied infrequently to a condition that progresses continuously and that requires regular, comprehensive monitoring to manage optimally. Most patients with stage 3 and early stage 4 chronic kidney disease have not been referred to nephrology, have not had their proteinuria quantified with a urine albumin to creatinine ratio, and have not had their management optimized for renal protection. They arrive at the symptomatic stage, the stage of this video, in a state of inadequate medical management because the disease was identified at an earlier stage and not treated with the urgency it warranted. That is a failure of the system, not of the patient. If you have recognized 2 or more of the 6 symptoms in this video, and particularly if you have a history of diabetes, hypertension, recurrent kidney infections, long-term NSAID use, or a family history of kidney disease, the appropriate response is urgent medical assessment, not watchful waiting. The window in which intervention substantially changes the trajectory is open at this stage, but it is not indefinitely so. The first action is comprehensive renal function assessment, going beyond a standard creatinine measurement. An eGFR should be calculated from the creatinine value and the result interpreted in the context of trend. A single eGFR of 35 milliliters per minute is less informative than knowing whether that value has been stable for 2 years or has declined from 55 over the same period. A urine albumin to creatinine ratio provides a quantification of proteinuria, the single strongest independent predictor of progressive renal decline and a primary treatment target in its own right. A urine dipstick for blood and protein, a serum electrolyte panel including potassium, sodium bicarbonate, phosphate and calcium, and a full blood count to assess the anemia of chronic kidney disease should all form part of the initial assessment. Research published in Kidney International has established the combination of eGFR and urine albumin to creatinine ratio as the minimum diagnostic framework for staging chronic kidney disease, predicting its trajectory, noting that either value alone significantly underestimates disease severity in a proportion of patients. The second action is optimizing the management of the primary disease drivers because chronic kidney disease does not progress in a vacuum. The 2 most common and most powerful drivers are hypertension and diabetes, and both require management that is specifically calibrated for renal protection rather than simply for cardiovascular risk reduction. The blood pressure target in chronic kidney disease with significant proteinuria is 120 to 130 millimeters of mercury systolic, more stringent than the general population target. And the first-line agents are ACE inhibitors or angiotensin receptor blockers, which reduce intraglomerular pressure directly and reduce proteinuria independently of their blood pressure effect. Research published in the New England Journal of Medicine has demonstrated that SGLT2 inhibitors, originally developed for type 2 diabetes, produce significant renoprotective effects in patients with chronic kidney disease, reducing the rate of eGFR decline and the risk of kidney failure in patients both with and without diabetes. These agents are now recommended in international guidelines for kidney disease management, and if you have not been offered them and your eGFR is below 60 with significant proteinuria, that is a conversation worth initiating with your clinician.